Next up on the agenda, we have Katherine Walsh, who is a consultant geriatrician at Southmead Hospital in Bristol. She's going to be talking to us about anemia in the elderly. So Dr. Walsh has got a number of interests in terms of orthogeriatrics, osteoporosis, and the perioperative care for elderly people. Is the joint clinical lead for a trust for the National Hip Fracture Database, and also clinical lead for morbidity and mortality in elderly trauma. Yeah, so Katherine, I'd like to hand over to you, and thank you for coming to present with us today.
Thank you very much for asking me to present to you. Anemia in the elderly is a very big topic. And I'm not particularly an expert, but I do have several years of experience of managing older patients with anemia who also are presenting with trauma. So that's what I'm going to be focusing my talk on today. Sorry, can I just check that you can see my slides moving? Is that, I got the same problem as...
Yeah, so if you I can see your mouse. Do you want to try just moving the slide on? I've got your first, yeah, the slides are moving on. So it's currently on the aging volume.
Oh,
yeah.
Hang on a minute, let me go back. Sorry. There we are.
Perfect.
So as I said, yes, I'll be focusing mainly on trauma, but I will just give a brief overview about the aging process and some causes of anemia before sort of letting you know why that's important in patients that have got trauma. And then I want to just finish by going through some case examples just to try and illustrate some of the issues that we might come across. So as we age, there is a progressive physiological change which affects every bodily system. And this is normal and it can occur in older people, even those people that are well without clinical disease. So our reaction times and our reflex responses get longer, and our ability to react to illness is delayed. Our physiological reserve is reduced, and therefore any small change or insult to the body can have a big impact on our clinical health. And this process also affects the immune system, which is called immunosenescence. And there is an age-associated upregulation of the inflammatory immune response with high levels of pro-inflammatory cytokines. And this sort of, it's given an odd term, it's called inflammaging, and it can offer an explanation as to why there are high levels of anemia in otherwise healthy individuals. And just for ease, anemia can be grouped into three main categories. Those anemias that are based on iron, folate or B12 deficiency, of which iron deficiency is the most common. And in older people, this tends to be a GI pathology, usually a cancer. And then anemia is based on chronic inflammatory disease or chronic kidney disease. And it's estimated that about a third of elderly adults presenting to an acute hospital setting will have some sort of hyperinflammatory state. This is on top of the inflammaging process with age, and there are multiple medical conditions that can lead to that. And then the third group of anemias would be those that are hematological or malignancy. And the sort of underlying sort of pathophysiological mechanism for this really is due to an overproduction of hepcidin. I'm very sort of simplifying this here, but hepcidin can cause a negative impact on erythropoiesis. There's also a blunted response of erythropoietin in the face of anemia. So the overall effect is bone marrow suppression. And the prevalence of anemia rises. So it's estimated that in over 85-year-olds, there's approximately a 45% rate of anemia. So what does all this really mean? Well, just to summarize what I've said so far, there's a high proportion of pre-existing anemia in our patients that come in to hospital with trauma. There might be multiple causes for this, and often there's more than one active cause or disease process occurring at the time. Therefore, the diagnosis and management of these patients can sometimes be very complex. And we know that in trauma, there will be a predictable amount of blood loss. So we expect fractures that occur in longer bones, for example, femoral fractures, to bleed more than those fractures that are occurring in small bones. We also know that open injuries tend to have twice as much blood loss as closed injuries. And those patients that are requiring specific procedures that are high risk, such as a complex open or revision procedure, we expect blood loss to be significant, up to 2 litres in some cases. Unfortunately, all of these figures don't really make for happy reading. We know that age is an independent predictor of poor outcome following trauma. And you might hear about the use of clinical frailty scoring, and that seems to be becoming more commonly used instead of age, but particularly in sort of research fields. But we know that both age and clinical frailty correlate with outcome. We also know that older people sustain a more severe injury when you can compare it to a similar injury mechanism in a younger person. And falls are the main cause of injuries in older people. Up to 75% of cases are minor, usually just a fall from standing height. As I've said to you before, in older people, there's impaired physiological responses. This often masks the level of injury, and this can lead to under triaging at the scene and delay adequate resuscitation. Older patients are often on anticoagulants or antiplatelet agents to treat their underlying medical problems. So anemia contributes to poor post-op recovery, poor wound healing, and increased infection rates, which ultimately leads to an increased length of stay and increased costs. So what can we do about this? Well, thankfully there are lots of guidelines, and I've included some of the ones that we use on the screen here. But there's a caveat to that, because not all of these guidelines are based on evidence collected from older people. So using hip fracture as an example, there are multiple studies in hip fracture, but not all of these include older patients. And often the outcomes or the conclusions are conflicting or not robust. And that's required us to have to extrapolate the results to this elderly group of patients. In addition, the outcomes looked at in trials are not often relevant to older people, in that they often look at mortality, whereas a lot of older people, things that are important to them are whether they can get home and what their quality of life might be after their injury. And with regard to anemia management, we know that pre and post-op anemia is common, but in trauma, in the elderly particularly, there's not really any clear evidence on what the optimum target should be, and also there's conflicting evidence on the use of IV iron. So I'm sure probably most of you are aware that the transfusion committees and patient blood management groups across the trusts in the country have worked to navigate all of this evidence and pull together the evidence to formulate guidelines that include things such as the use of tranexamic acid and intraoperative cell salvage. And the document that you can see on the right, that's the North Bristol guideline for the use of these products in hip fracture surgery specific. So what's the role of the geriatrician in all of this? Well, really, it's just to help pull together all the different aspects of the patient's care and help facilitate an appropriate and individualised perioperative care plan, but also to communicate that both with the patient and the family, but also between all the various different teams that are involved in their care. So I'd like to move on to some cases now. The first case is of a 92-year-old male, and he fell at home, resulting in a hip fracture, and this is his X-ray on the screen. So at presentation, his active medical problems was that he was anemic with a hemoglobin of 98. He also had untreated prostate cancer. His previous medical problems included bowel cancer, which he'd had treated with a hemicolectomy, and he'd had pulmonary emboli and was on lifelong apixaban. The orthopaedic team had stopped the apixaban on arrival, and they, after assessment, had planned to do a dynamic hip screw operation on the following morning's list. Just a quick aside about delaying patients who are on anticoagulants. So I've included a paper there that was actually authored by one of my colleagues, showing no adverse outcomes in going ahead with surgery for patients on anticoagulants. So currently at North Bristol, we do not delay surgery, but in practice, most people get operated on the following day. So for this gentleman, his bleeding risk was moderate. He has a long bone fracture and he is on apixaban, so will bleed more. He's waiting overnight for his operation, but he will be having a low risk operation. However, he is already anemic, and with the injury that he sustained, he's highly likely to drop his hemoglobin by at least 2 grams. And in view of his frailty and his other medical problems, it was felt that this level of anemia would impact his rehabilitation potential. In addition, it was highlighted that this man really needed a discussion regarding his choices for treatment and some advanced care planning to put in appropriate levels and ceilings of care before he went to theatre. He had a complete review of his medical history and his anaemia, and he had been anemic since 2021, and this had been fully investigated by his GP, who found him to be iron deficient, and he had been started on oral iron at the time. His previous CT had showed no evidence of recurrence of his bowel cancer. He had been referred to the urology team for a complete workup of his prostate cancer, but there had been a joint decision with the patient and the team not to proceed to any treatment, but they were actively monitoring him. On his last bone scan, there had been no evidence of bone metastases. During his clinical assessment in hospital, there was no evidence that he was actively bleeding from anywhere other than his femur, but he was found to be have an ongoing iron deficiency despite taking oral iron. So the causes for his anemia at this point would be a low-level inflammation from his prostate cancer plus inflammaging. It's also likely that he was malabsorbing his iron. And there was also a concern that possibly his cancer had recurred, leading to undetected colonic bleeding. And he'd had an acute blood loss from his femur. On further discussion with the patient, he did not want any further investigations for his cancer or any life-prolonging treatments, but he did agree that we could treat his anemia or any symptoms arising from that. So he had a pre-op infusion of Ferinject, and 1 unit of blood was cross-match ready for it to be given intraoperatively. He did have his unit of blood in theatre, and his HEMA-Q level was 89 in recovery. He did have some low blood pressure episodes on day 1, which was mainly during physiotherapy, and this was managed by introducing graded physiotherapy, graded sitting and standing, and using a specialist tilting chair. His repeat hemoglobin level was 97, and actually it remained stable throughout the rest of his admission. It was 103 on the day of discharge. His wound healed well with minimal hematoma, meaning that his apixaban could be restarted at day 2, and there were no further complications with regard to that. He was discharged from the hospital to a rehab facility at day 15. And we had good outcomes for this gentleman in terms of being able to discuss the benefits, risks, and the alternatives of all his treatment options and come to a good decision for him, including advanced care planning and completion of a RESPECT form. Case 2, so this is an 80-year-old male, and he had a fall which resulted in a periprosthetic femoral shaft fracture, and you can see his x-ray here shows that he's got an extensive spiral fracture of his femur, ending at the tip of his prosthesis with a little bone spike sticking out below. On arrival in the emergency department, his active medical problems was that he was anemic, with hemoglobins ranging between 108 to 117. His previous medical problems, as established on the sort of initial clerking, was that he had a history of ischemic heart disease and had had a bypass graft in 2010. He was on lifelong aspirin following this. He was a type 2 diabetic, but this had been reasonably stable on oral medication. He'd also had a history of urethral strictures, for which he'd performed intermittent self-catheterization and intermittent self-dilatation. After his assessment, he was deemed to be stable for theatre, but the orthopaedic team knew that there'd be a predictable long wait for an operation in view of the fact that he had to wait for a specialist surgeon and the specialist kit to arrive. But his aspirin was withheld from admission. So his bleeding risk is deemed to be very high. He's got a shaft fracture on aspirin and having to wait a long time. He was also going to require an open and complex operation, which would likely lead to approximately 1 to 2 litres of blood loss. He did have his operation on day 3. Unfortunately, he did not get any repeated blood tests pre-op or any other repeated medical assessments pre-op. Intraoperatively, he received tranexamic acid, but no cell salvage had been set up. His HemoQ level in recovery was 80, and he was actually stable at that point in time, deemed well enough to return to the ward. And his rechecked hemoglobin that evening was 82. Unfortunately, he developed an episode of chest pain when he was attempting to mobilise out of bed the following day, and an urgent consultant review was requested at this point in view of the concerns that he might be developing a type 2 myocardial infarction. The significance of the low hemoglobin in this gentleman was recognised. Unfortunately, I think probably the admitting teams who'd seen him up to that point had missed the importance of a developing anemia in this man. On further questioning and exploration of his history, he hadn't been anemic until admission. His hematinics had been checked on arrival to ED, and his vitamin B12 level had come back at 150, which is low. It was also discovered that he had an extremely high alcohol intake, and this had been going on for approximately a year prior to admission. He'd also had recurrent urinary tract infections and some hematuria, which had continued up until his most recent urethral dilatation, which had occurred approximately 6 months prior to his fracture. All his other blood tests had come back normal. So the likely causes for anemia in this gentleman were possibly chronic inflammation secondary to his diabetes and his recurrent urinary tract infections, but it's much more likely to be blood loss due to his fracture and his history of alcohol and a new vitamin B12 deficiency. So the immediate management for this man was to start B12 loading and to start him on some alcohol detoxification, and he was seen by the alcohol liaison team. And his GP will be following all of that up in the community. With regards to his anemia and his potential myocardial infarction, he had an urgent repeat hemoglobin, which unfortunately came back even lower at 74, and he had ongoing problems with postural hypotension and low blood pressure. So 2 units of blood were given immediately, and he was confined to bed really until his hemoglobin and his blood pressure improved. After that, his hemoglobin level was stable for the rest of his admission. He did have a very large thigh, but this was treated by elevation in bed, and he didn't have any wound breakdown as a result. When he was eventually allowed to mobilise, he did quite well, and he had no further episodes of chest pain. There were some very minor changes on his ECG, and his troponin rises was small. Therefore, the cardiology team felt that it would be appropriate just to manage him with dual antiplatelets until they saw him again in clinic. So actually, despite all of this, he did really quite well with his rehab, so much so that he was able to be discharged home at day 12. Now, case 3, this is a 72-year-old female, and she had a fall over her front doorstep, which resulted in a pubic ramus fracture and a distal radius fracture. She also sustained some dog bites to her shoulder and her neck at the same time, and a very minor superficial head injury. Her medical history included mild cognitive impairment, but she was still able to function well and live alone. She'd also had an upper GI bleed due to some gastric erosions, but that was several years ago, and she'd not had any complications since. Unfortunately, she had a very stressful and prolonged transfer to the hospital, mainly because of the issues with the dogs, and she required quite a lot of paracetamol and Oromorph to help manage her pain throughout this time. In the emergency department, she ended up having sedation for her wrist manipulation, and you can see her x-rays here on the right before and after the application of a back slab, which improved her pain. At the time, her other assessment, all her observations and her bloods were all normal. She was referred to the plastics team to look at her wounds. These were explored and found to be satisfactory. There was no evidence of vascular injury, and her wounds were cleaned and able to be stitched up in the department. So at the time, her bleeding risk was felt to be quite low in view of the fact that she's got a small low risk pelvic fracture, and there was no surgery required. And she had no other relevant medical or drug history. Unfortunately, she deteriorated on the ward over the next 24 to 48 hours. She became very non-specifically unwell, and then became nauseous and started vomiting. She had a lot of ongoing pain, which wasn't really managed with her Oromorph, and difficulty weight bearing. On her repeated clinical assessment, it was found that her blood pressure was quite variable, and her repeated blood test showed that her hemoglobin level had dropped to 91. At the time, the orthopaedic team were a little bit unclear on how to proceed with investigating this lady and what might be the cause. So following a geriatrician review, the significance of this hemoglobin drop was explained to the team, and as there was no real evidence to support a gastric source or blood loss, it was felt that in view of her ongoing pain and difficulty mobilizing, it was highly likely that she had hidden injuries, and an urgent CT was requested. This image on the left-hand side is one of her images. I'm sorry, it's not very good, but it does show multiple pelvic, sacral and spinous process fractures. Her immediate management was to give a unit of blood and some IV fluid boluses in order to try and stabilise her blood pressure. At the time, we decided that we would start her on omeprazole, although there was no real evidence of a gastric source of blood loss because of her history of significant stress and trauma around the time of her injury. We felt that it was highly likely that she'd had a stress response and was at risk of developing gastritis. So she was given some omeprazole just to protect her stomach. But there was no evidence throughout the rest of her stay of any GI source of blood loss. She was, after discussion with the MDT involved, she was kept on the trauma discussion list, and this was really because of the extent of her injuries and the high risk for hematoma and infection. And the surgeons had a very low threshold for further imaging of her injuries, plus or minus surgery should this be needed. We did make the decision to only give her the 1 unit of blood, and this was predominantly because she wasn't really able to rehab effectively at that time. So the impact of her low hemoglobin was felt to be less important for her. However, it was regularly monitored, and we would have been able to give her further transfusions should she have needed it. The rest of her investigations were normal. In view of this lady's multiple injuries and psychological as well as physical trauma, we knew that it would be quite a slow rehab for this lady, and that she would need slow stream rehab on discharge. So we made the early decision to discuss this through with the MDT and with her family, just to manage their expectations really about how life-changing this injury might be for her. So she did have a slow stream rehab referral and was discharged eventually. So hopefully these cases have helped to just demonstrate the complexity that older trauma patients might pose, and the relevance of anemia in this group of patients. But by being aware of the impact that anemia can have in trauma, and having appropriate protocols in place and blood loss management strategies, you can actually provide some good outcomes despite the really poor prognosis and some that this group of patients does carry. So thank you for listening to me today. I've included some references there on the screen just in case you want to have a look at some of those guidelines that we use, but I'd be very happy to take either questions now, or you're welcome to email me if that's preferable. So thank you.